Welcome to AETCM, the emergency medicine channel. Shall I? Presenting the case of a 40-year-old female who presented with complaints of shortness of breath, which was gradually progressive since 2 weeks and aggravated since last 2 days. On initial 10-second assessment, patient was conscious and obeying commands. Patient was tachypnic. On airway assessment, patient was only able to speak in broken words. There was no gurgling, stridor or pooling of saliva. Breathing, patient had a respiratory rate of 38 per minute with a saturation of 80% at room air. At this time, we had connected the patient to NRBM with 15 liters of O2 and arranged for BiPAP ventilation. Air entry was bilaterally equal and bilateral crux was present. On circulation.
Why did you start the patient on NRBM?
Patient was very tachypnic and saturation at room air was only 80%.
True. That's mainly due to the hypoxia that patient has, right? So basically, patient is coming from home. This patient was not on oxygen. Why did you start NRBM? 15 liter oxygen NRBM as first treatment for a hypoxic patient. You could have given oxygen and seen how the patient responds to it, right? Like you could have started a face mask at maybe 6 liters or maybe max 8 liters and see how the patient responds to it. Here also in NRBM, you are starting NRBM and you are waiting for BiPAP to initiate. So why didn't you start with the oxygen delivery device like normal face mask? Could have started, right? Okay.
On circulation, patient was maintaining a BP of 130/80 mmHg with a heart rate of 97 per minute. All peripheral pulses were palpable and CRT was less than 2 seconds. At this time, 2 large bore IV cannulas were put. Coming to the disability, patient had a GCS of 15 out of 15. Pupils were 2 mm and equal and reactive to light. Patient had a GRBS of 115 mg per deciliter. On exposure, patient was febrile and hypothermia was prevented by providing a blanket. At this point of time, we has already also done a bedside USG, and on bedside USG, it was showing multiple B lines were present on bilateral lung fields. Coming to the adjoints of the primary survey, we have taken the ABG of the patient, and in the ABG was showing a pH of 7.1 with a PCO2 of 24.2, bicarbonate of 7.2, creatinine of 17.9 and a potassium of 6.9. So at this point of time, we had taken an ECG since there was hyperkalemia. It was showing a hyperkalemia, and in the ECG, it was showing a sinus rhythm with tall T waves in all leads. So we had gone ahead with anti-hyperkalemic measures. We had given the patient GI bolus. We had also nebulized the patient with 3 times with nebulization Estalin, and we had also given injection calcium gluconate 10 ml 10% over 10 minutes. Then we had also taken a chest X-ray for the patient, and the chest X-ray was showing bilateral infiltrates from the center to periphery, which was less in the upper lobes. Also was showing a left-sided effusion. Then at this point
left-sided unilateral effusion.
Left-sided unilateral effusion was there. Also, we had sent a point of care CBC CRP, which was showing a total count of 12,000 with a CRP of more than 170, and HB was 6.9 with a platelet count of 3 lakhs. Coming to the secondary survey, 41-year-old female who was accidentally found out to be single kidney and also known case of CKD, presented with complaints of shortness of breath since 3 weeks, which was gradually progressive in nature. It got aggravated since last 2 days. Patient also has complaints of decreased urine output and worsening of bilateral pedal edema since last 2 weeks. There was no history of any fever, cough. Patient also complains of diffuse abdominal pain, which has been started since last 5 days. Allergic history, patient has no allergic history. Medical history.
Diffuse abdominal pain for the past
last 5 days. Medical history, Patient was on alternative medicine therapy for CKD, and past history. Patient, while performing an USG scan for infertility workup in 2018, was found to be having a solitary kidney. And at that point of time, creatinine baseline RFT was done, and creatinine was found to be normal. Following the next year, patient had developed severe headache, and on evaluation, patient was found to be hypertensive. At that time also, creatinine levels were found to be normal, and for hypertension, patient was taking Ayurvedic medicines. In 2023
Those
also.
reports were there, that baseline creatinine being normal was documented, or was it said by the bystander?
Was said by the bystander. And then following years, she was not on any medicines, and in October 2023, when she had an episode of fever, at that time she had been admitted in outside hospital and found to be have a creatinine of 6. Since then, patient was on regular checking for creatinine, and it was on a worsening trend, but she was on alternative medicines, and she was continuing on those medicines. Coming to the that was the past history. Coming to the general examination of patient, there was no pallor, icterus, clubbing, lymphadenopathy, bilateral pitching pedal edema was present. Coming to the system examination, respiratory system on inspection, there was usage of accessory muscles present, trachea was central, there was bilateral symmetrical chest movements. On palpation, trachea was central. On auscultation, air entry was bilaterally equal, and bilateral crepitations were present on all lung fields. Coming to the per-abdomen system examination, per-abdomen was soft. Patient was having a mild diffuse tenderness. There was bowel sounds was present. Other systemic examinations were within the normal limits. So at this point of time, we had arranged the BiPAP for the patient. We were going to put the patient on the BiPAP ventilation, and we had connected the patient to the BiPAP with a IE ratio of...
By the time you were putting the BiPAP, what was patient saturation?
Patient was maintaining a saturation of 96 to 98.
On 15 liter
O2. No. So we had connected the patient to BiPAP with an IE ratio of 12:8 we had put, but after 10 to 15 minutes, patient was not tolerating the BiPAP, and patient was not allowing to keep the BiPAP. Hence, we had to shift from the BiPAP to the NRBM itself. We had shifted it. Patient was not allowing. Patient's respiratory rate was still on a higher side. It was between 35 to 38 itself. So then we had given the patient a bolus dose of injection furosemide. 40 mg stat was given for the patient, and also BP monitoring was done. Hourly BP monitoring was done, and BP was maintaining around 120 to 80 mmHg. So we had also given at this point of time a nephro consultation in view of elevated creatinine levels. Creatinine levels were found to be 17 in the VBG, and nephro consultation was given, and we were planning for an emergency dialysis in view of severe metabolic acidosis and hyperkalemia.
Impression?
We had a working diagnosis of nephrogenic pulmonary edema.
Patient was diagnosed to have hypertension, right?
Yes.
So was she on antihypertensives or alternative medicine?
Alternative medicine.
No, so not on antihypertensives. No. Okay. So nephrogenic pulmonary edema. Okay. So what are the differential diagnosis for pulmonary edema?
When a patient can develop pulmonary edema due to...
No, what are the differential diagnosis for pulmonary edema? Not the causes of pulmonary edema. What are the differential? You have a, see, in this case, you have a patient with progressive breathing difficulty for 2 weeks duration with acute worsening of 2 days. You got a creatinine of 17, you are expecting fluid overload, you got pitting pedal edema to support your diagnosis and you got bilateral crepitations, isn't it? So you are saying it's a nephrogenic pulmonary edema. So I am asking, what are the other differential diagnoses for pulmonary edema?
It can be a simple worsening of LRT, acute exacerbation of bronchial asthma or COPD.
Yes, but your X-ray is showing bilateral infiltrations with central infiltrations more than the periphery.
We can suspect ARDS in the patient.
ARDS. So that is one thing. So it's not a simple LRTI or bronchial asthma and all. We should suspect with that X-ray finding. Not this much protracted history. 2 weeks is too long for ARDS, but ARDS is a possible differential diagnosis. What else?
Any cardiac events?
It can be a cardiac event because patient was having 2 weeks of breathing difficulty, acute worsen for 2 days only, isn't it? So acute worsening is the cause that we are looking for. It can be a acute cardiac event causing cardiac failure with LV dysfunction causing acute cardiogenic pulmonary edema. What else? You yourself told patient was hypertensive, but right now your BPs are normal. But if your total counts was?
Total counts was 14,000.
14,000. CRP is more than 170. So there is significant infection, right? So can infection cause, other than ARDS, can infection cause any acute breathing difficulty patterns?
Sepsis-induced metabolic acidosis can.
Metabolic acidosis can be attributed to sepsis, and because of metabolic acidosis, compensatory respiratory efforts can cause tachypnea, but will not cause desaturation, right? Desaturation means there is pulmonary involvement. So what infective cause will cause pulmonary involvement other than ARDS, especially in dengue, lepto, pulmonary hemorrhages, diffuse alveolar hemorrhage, not pulmonary hemorrhage, diffuse alveolar hemorrhages. It is a differential diagnosis for ARDS, pulmonary edema and all. Then, so these are the things we should consider. There are other conditions also, but these are things that we should consider. What else? This patient's history, you told it's nephrogenic pulmonary edema. Okay, but this is a patient who is a long-term CKD, not initiated on any treatment, any modern medicine treatment, not on dialysis. Patient was doing fine, right? Like with creatine cysteine, it's not like yesterday she was normal. It is a long time coming. Patient is having progressive breathing difficulty. Your X-ray shows bilateral infiltrations. As a differential diagnosis, what other kidney-induced condition can look like pulmonary edema? Or what CKD condition can look like pulmonary edema as a differential diagnosis? It's not very common nowadays because many of the CKD patients go for early dialysis, so we don't get this very common, but it can happen to such a patient. Uremic lung. Uremic lung is a condition in which, due to CKD and urea presence, permeability of lung membrane increase. So let's come to that. So we have a couple of differential diagnoses now. So at the end of your presentation, you should always have a couple of differential diagnoses. Then you should do your investigations and your other modalities to diagnose the condition. With the history and examination itself, you have single diagnosis. There is a high probability that you will miss something else in ER. When you have time and all, it's fine. In ER, you require other modalities to support you. So let's think about these differentials. Then let's rule it out. So DDs of pulmonary edema, you told. Now, as you are going to say, what is the cause for pulmonary edema?
It can be cardiogenic pulmonary edema, nephrogenic pulmonary edema, neurogenic pulmonary edema. It can also be due to any toxin intake such as salicylate or opioid poisoning. Then it can be due to ARDS as told.
So basically,
TRALI also can cause.
Pulmonary edema is basically classified into two, cardiogenic and non-cardiogenic. So basically, pulmonary edema, basically it's a shift of water from blood vessels into the alveoli, right? So in cardiogenic pulmonary edema, the pathophysiology is very clear. It is due to the increased pulmonary artery wedge pressure because of LV failure. LA pressure increases, which is transmitted into the left pulmonary vein, increasing pulmonary capillary pressure, causing the hydrostatic shift. It's a very clear process. That is why it is called as cardiogenic pulmonary edema. And all other conditions, whatever else you told, comes under non-cardiogenic. The problem with non-cardiogenic is, basically we are telling that, we are assuming that LV is normal, or the cardiac component causing pulmonary edema is minimal to zero. In a patient who comes with a acute symptom, multi-organs can be involved. So we can never rule out saying that this patient doesn't have pulmonary edema, but we are saying that there is multifactorial involvement. All other causes of pulmonary edema is mainly due to the increased permeability of the alveolar membrane or vascular membrane to the fluids. It's not due to the increased pressure effect. So it's not like CKD patient develops increased fluid overload and fluid seeps out. It is basically due to the inflammatory mediation causing vascular bed to be more porous, so it goes out. So that increased permeability or inflammation can be due to infections like ARDS. ARDS is secondary to infection. It can be due to kidney injuries, for example, uremic lung. It can be due to the inflammation due to transfusion related, that is TRALI. It can be due to trauma causing inflammation, like single lung pulmonary edema conditions are there. So it can be due to the lung contusions as such. Then it can be due to re-expansion, a collapsed lung due to pneumothorax or hydrothorax, already collapsed lung more than 72 hours, you suddenly re-expand. That is causing inflammation. That is re-expansion pulmonary edema. Similarly, all other conditions, and neurogenic pulmonary edema. Neurogenic pulmonary edema is when you undergo either a significant traumatic brain injury or a traumatic brain surgery, following which you develop acute pulmonary edema, bilateral pulmonary edema, without any cardiac involvement. So basically it should be non-cardiac, isn't it? So these are the basic classification. So what is the, how do you differentiate these things? What are the tests or diagnostic methods you can do to differentiate cardiac and non-cardiogenic pulmonary edema?
On coming to the symptom-wise differentiation, if it is a cardiac cause, then patient will be having severe tiredness, patient will be complaining of exertional dyspnea, orthopnea, PND, patient can have pre-syncope or syncope, patient may develop palpitations in cardiac causes. If it is a nephrogenic pulmonary edema, then patient may complain of decreased urine output or anuria. Patient also may develop bilateral pedal edema or ascites as such. In neurogenic, it will be on acute onset. It won't be a gradually progressive.
Associated with neurological symptoms.
Neurological symptoms will be there. In TRALI-related pulmonary edema, it will be also an acute, followed by a transfusion, blood transfusion in the patient. Then other toxin-related, everything will be on acute basis.
Yeah, all others are very acute involvement. Kidney injury is one of the conditions which can present as a chronic condition. So history helps you a lot, isn't it? So what are the other modalities you can rule it out?
On the basis of signs also, you can have patient may develop bilateral pedal edema, patient can have ascites, patient may develop JVP elevation can be there. Then patient in cardiac causes, patient can go for hepatomegaly can be there.
Congestive
hepatomegaly
so
can be there.
In fluid overload conditions, you can have all these conditions you told. So CKD, cardiac failure, these conditions are common. And non-cardiogenic, only CKD will have this, TRALI, trauma, re-expansion pulmonary edema, your toxins, ARDS, all these things will not have these fluid overload symptoms, isn't it? Okay. So how do you rule out cardiac versus non-cardiac, means renal?
Okay. On investigation basis, if to differentiate between cardiac and non-cardiac, pro-BNP can be used. Pro-BNP levels will be elevated in
what
cardiac.
What is the normal pro-BNP level?
Above 5,000 can be considered as a cardiac cause for pro-BNP.
Pro-BNP, like in clinical practice, when you say this, it is understandable. Like we can understand. You're thinking about multifactorial, but pro-BNP's normal value is less than 500. More than 500 is abnormal, and more than 750 is diagnostic for cardiogenic failure, ventricular failure. It's diagnostic for ventricular failure, more than 750. So there is a age-related variation of pro-BNP in which you take it more than of 1000 levels also. But then also it's not 5,000. Okay, but clinically, when we speak, when there are multifactorial, we say that more than 5,000 should be clinically important. But a patient who is purely presenting with cardiac symptoms with a 1,500 proBNP, you should suspect it is LV failure. So don't blankly say 5,000. Okay.
Anti-proBNP can be used. If it is a nephrogenic, then we have to go for the RFTs of the patient.
So is, as you told, proBNP, is proBNP very specific for LV failure?
No.
No. Can it be altered with other conditions?
Yes.
What is one of the most common conditions that will
CKD itself.
CKD. So that's why you told a higher value, but that we should mention, no? That is why you told a higher value. But proBNP is specific when symptoms and signs points towards a cardiac condition, but it can be altered by other conditions also. Then nephrogenic
RFT should be done, and in that high creatine levels and urea levels can
urea
be
levels should be looked at. And in symptoms, you can look for other uremic symptoms, uremic gastritis, uremic pericarditis, uremic encephalopathy. These features you can look for. Patient is having flapping tremors, patient is having central chest pain with ECG showing pericarditis like symptoms, or patient is having severe intractable vomiting. Other uremic symptoms is there, you can think about uremic lung also. Okay. So these are the signs and symptoms and common blood investigations, right? So you should send routine blood investigation, because we have infective causes also. Our DD is one is ARDS also. So you need a total counts CRP levels to see infection. You need a RFT to assess the renal function. We need a proBNP, cardiac enzyme. It is a 2-day history of acute breathing difficulty. What if it is a NSTEMI causing cardiac failure? ST elevation, definitely we would have picked up in ECG. We didn't get a ST elevation in ECG, but ECG changes are there, right? So cardiac enzymes to see rising troponin levels. So cardiac enzyme every 6th hourly we need to send in this patient. You need to look for other sources of infection, isn't it? Infection can cause DIC, can cause multi-organ dysfunction, causing ARDS-like features. So any sources of infection, cellulitis, UTI, any pyelonephritis features, all these things has to be ruled out. Okay. So coming to investigations, you told these parts. Okay. Even though these blood tests you told proBNP and all, we told it can be altered with CKD also. How can you diagnose, or how can you really rule out cardiac failure?
By doing an echo in the patient.
Yeah, you need to get an echo done and look for
any LV dysfunction.
LV dysfunction. So if a cardiologist is telling an echo is good or there is no LV dysfunction, you can really attribute it to renal failure alone. But what if patient already has a LV dysfunction, like mild LV dysfunction? Patient had a MI 1 year back or 2 years back. Patient has mild LV dysfunction. Previous ejection fraction is 55%. Now you are doubtful. Your nephrologist is telling it can be cardiac also. What is the actual diagnostic way you can diagnose? You can rule out cardiogenic pulmonary edema. In ER, no one does this. Not even in critical care nowadays, very, very rarely people do this. But what is the actual way? You measure pulmonary artery wedge pressure. So you insert a Swan-Ganz catheter into pulmonary artery and measure the pulmonary artery wedge pressure. If it is less than 18, you are saying that cardiac is not there. But very rarely people do this. Not even in critical care. In emergency, no one does this. Not even in critical care people does this, but we need to know that. Okay. So what is the primary management? So let's come to that. Primary management in this patient. So initially this patient is presenting to you with a 2 weeks history of breathing difficulty that is progressively increasing. You told bilateral pedal edema progressively increasing, decreased urine output, 2 weeks of breathing difficulty, exceptional in nature. So typically a fluid overload features, right? And 2 days worsening. Now, your total counts are elevated, CRP is 170. Now that is not a nephrogenic pulmonary edema, right? There is some amount of infection happening here. There is no doubt in that. So that infection has pushed the patient into a acute renal failure. So this is a AKI on CKD, which is worsened with a infection. Now the source of infection, isn't it? You told there is no fever, no cough, no sputum production, so it's highly unlikely to be LRTA. But one thing you told is X-ray showing left-sided pleural effusion. Now, in a CKD patient, we expect fluid overload. We expect there to be a transitive pleural effusion, which should be bilateral. You have a unilateral pleural effusion. With total counts and CRP, you should suspect there is an underlying pneumonia there, isn't it? You have done an ultrasound lung, you got bilateral B lines. Did you get any starry sky appearance or fishtail appearance of the lung on the left side? Did we look for consolidation? So that is one part we could have done, because we already know there is an infection. We know unilateral pleural effusion. So if it is an infection, it makes perfect sense. I am not saying it is not nephrogenic pulmonary edema. I am saying it is a nephrogenic pulmonary edema, but the underlying sepsis part should not be missed out, isn't it? Because antibiotics will play a crucial role here. Now, ultrasound of this part can be done. Oh, coming to management. So basic management should be oxygen for this patient, right? Patient coming with 21% FiO2 is what you are seeing at 80% saturation. You should have started with a face mask and saw how the patient responds to it, isn't it? And then only you should have triggered for a NRBM and all. Patient may respond, may not respond. You may have to hike up in the middle. That is irrespective of the fact. Okay, but anyhow, you started NRBM, then you started BiPAP. Now, why did you initiate BiPAP? What was the rationale for it?
In fluid overload conditions, the EPAP to support the patients.
Use the words correctly. Do you start EPAP for fluid overload conditions or pulmonary edema?
Pulmonary edema.
Pulmonary edema. Otherwise, its fluid overload is basically in third space. You don't put BiPAP for third space patients. So, pulmonary edema conditions.
In pulmonary edema conditions, during the expiration, there is a chance for the collapsing.
There is collapse. There is alveolar collapse.
So, in order to prevent that collapsing, we give the positive pressure, and thus we put the patient on BiPAP so that inspiratory pressure and an expiratory pressure can be given for the patient. And we keep the PEEP more so that to prevent the collapse.
Yeah, so basically to prevent alveolar collapse, which will increase patient's effort during each inspiration, we give a end expiratory positive pressure, which is called as PEEP. Which in BiPAP terms, PEEP is called as EPAP. So we give a higher EPAP more than at least 6 so that we can prevent alveolar collapse. So that's the idea that you started BiPAP. Okay, but then you had a problem. Right, patient was not tolerating BiPAP. So why didn't you continue BiPAP? If your patient was saying she is not comfortable with it, it doesn't matter. It's going to help the patient. No, why didn't you continue that? What is the problem in continuing BiPAP in a non-tolerating patient? What will happen? Patient taking breath through mouth or nose doesn't matter, because positive pressure air given by us doesn't know to go whether to stomach or trachea. It will go through all the orifices. So it will go to abdomen. That is why BiPAP, one of the complications of BiPAP is aerophagia. So that's not the thing. The thing is patient may not synchronize with the BiPAP. That is the thing. BiPAP will give inspiratory pressure when patient may be expiring. That asynchrony will worsen patient's tachypnea and breathing difficulty. That is why you couldn't continue and you had to remove, which makes sense. What you could have done to make the patient more pliable towards your BiPAP?
Anti-anxiety measures can be
Yes, patient is having breathing difficulty. Some patients may have claustrophobia. Some patients may have difficulty when there is high pressure of air suddenly coming to their face. This is a positive pressure ventilation we are giving, right? Even when you give NRBM, it doesn't generate positive pressure. So first of all, we started positive pressure a bit high here, 12:8. 8 EPAP or 8 PEEP we are giving, which is a good enough positive pressure to initially give to a patient. Some patients who is not used to this may find that very discomforting. So in such a patient, initially you can try, if patient is not responding to you, you can try for a lower PEEP, lower EPAP level, and gradually hike it. You start maybe at 5, see whether patient is responding to that, and patient says, I am comfortable in this, then slowly you hike it over 15 minutes or 30 minutes, patient may respond to it. You may not be needing to remove BiPAP together. Because when you remove BiPAP, you cannot give any PEEP, right? You can do that. Or you can give anti-anxiety medicines, but that depends on patient's condition. We can't blankly tell to give anti-anxiety medicines for all patients who is having BiPAP distress. But you need to look at patient's vitals, BP, heart rate, whether patient will be able to take good amount of breath after the anti-anxiety medicine. So we can recommend that as such. Okay, but you removed BiPAP and you started on NRBM, and patient was maintaining saturation, right? More than 96%, but with 15 liter oxygen, which is a very high amount. So this patient worsens, what will you go for?
Go for intubation.
You will have to intubate. So if this patient's BiPAP, since the patient had a BiPAP failure, that's the time you should have taken a consent for intubation. Because then you don't know when the patient is going to crash, and you should not wait for it. As patient progressively worsens, you should have taken the decision for intubation, and consent should have been taken when the BiPAP failure happened. That is one thing we should have thought about. What is the next level? So these things you are given a furosemide bolus dose also, no? 40 mg stat dose you are given. Any output?
No, urine output was there, but it was reduced.
Reduced, but she was already having CKD reduced urine output. But did the bolus give any increase in urine output?
No.
Nothing. But for that, you need a Foley sensation. Then only you will understand that. So Foley sensation should have been mentioned in this. I know that it must have been done, but we should have mentioned it also. What is the next thing?
Then we had started on infusion. Furosemide infusion was started with 10 mg, that is 1 ml per.
But doesn't matter. You are given a Lasix means furosemide bolus. It didn't give you the expected results. You have a patient who is non-compliable to BiPAP, who is having severe desaturation, who is having hyperkalemia, and who is having acidosis. What is this patient candidate for?
Dialysis, emergency dialysis.
Emergency dialysis. This is a patient who is a candidate for emergency dialysis. So once dialysis is done, extra fluids will be removed and patient will be fine. We did?
Yes.
It. So in between you told hyperkalemic changes were there and you supported, no? So any other hyperkalemic changes were there or?
No, only tall T waves was there.
Tall T waves were there. Anything else?